So I'm sorry that I'm between you and the lunch, but we will do, he is between them, okay. So first of all, it is a great pleasure to be here, and we are enjoying the cases and very lively discussion. My job is to say minimalistic TAVR. There is nothing minimalistic about TAVR. It's aortic valve replacement. We are doing it in low-risk patients. So I always say that you have to be fully aware of what you're doing. Do not do anything hasty. There is no rush. Take your time and do it well. This is our palace, you know, like Caesar's palace. This is where we do our TAVRs. So we do still do it in a hybrid room. And the hybrid room is so big that we have one wall for cardiac anesthesia, one wall for cardiac surgery, one wall for cardiology to store the equipment. The room is large, but there's nobody there. So we still do it with minimal people. So we have all the equipment, we have all the facilities available to go and pump. Our goal is to go and pump within 3 minutes. So if we want to do an aortic stent graft or go and pump, we should be able to do it in 3 minutes. So this is our ultimate goal. So this does have a pump, which is prime for all the ORs. So all the ORs have one extra pump. We have 15 ORs running every day. So one of the common pump is there. There is anesthesia, nurse practitioner. We do not anesthetize anybody. In the last year, we had no general anesthesia. Cardiologist and cardiac surgeon both are scrubbed. Echo technician is available, no echocardiographer, transthoracic echo, and one nurse is there. So people are minimal. No Swan-Ganz, no urinary catheter, no art line, no Foley, none of that. The access is minimal in the sense that we go in one groin. So we stick the groin, and one groin, as you see, there is there is one Perclose, one ProGlide, and underneath that, we stick the groin again. And then we stick one other groin for the venous puncture. So there is no contralateral access, there is no crossover, none of that. So just one side access. So patient goes, when he goes, they don't know that there are multiple catheters, just one side groin access. And at the end of the procedure, we take a picture from the underneath sheath. So the sheath that was removed, you see the little dent there. So when one Perclose was placed, if one Perclose later, if it still is oozing, we put one angiosil. And then we take the picture from the groin underneath. We don't have to cross nothing. There is a catheter already underneath. We take a picture. If there is a problem, we just put a balloon from underneath catheter. So that way it solves the problem. And at the end, we just hold manual pressure for these two sheaths. We publish that to say that the unilateral access, this is in JACC intervention, that unilateral access is a very simple procedure. Our complication rates are already falling, and it's even less. And serious complication, major bleeding is 1.9%, very, very rare. If you look at the unilateral access versus bilateral access, these are the detailed complications, and hematoma is the most important complication, and stenosis that requires the balloon dilatation. Again, if they require balloon dilatation, we balloon dilate it. But this is very simple, as I show here on the other side of the graph, that you can see it, that we just go from underneath. Just put a 6 or 7 millimeter balloon, put it through the sheath, inflate the balloon, pull back, and then inflate it fully. So very, very simple procedure. And single versus double Perclose, that also we published to say that we don't need two Percloses. So just one ProGlide, and 30% of the times, 30 to 40% of the times, we do not need anything else. If we need something else, we put one more angiosil. So we again save money, and we have no penalties to pay. We always use Sentinel, as I mentioned before. So we have a Sentinel, a radial sheath, and we put the Sentinel device, as you have seen now. We are deploying the proximal disc, and then we flex it. This is live. So then we just flex it, and we don't do any aortograms, no angiograms, nothing, just by where in the LAO, where the carotid is. And we do know it by the CAT scan, how the carotid looks. So we exactly know it's a bovine arch or not a bovine arch, type 3 arch or not. Typically, this is a very simple procedure. And here, as you see, I'm pointing with the arrow, that's where the carotid should be in this particular patient. So here the wire goes up, and then you just deploy the second filter, as you see. And as I'm talking, we have to spend less than 1 minute. Stroke is still a complication. And if you look at it, in-hospital mortality of the stroke patient is 12.7%, 30-day mortality is 16.7%. This is from the TVT registry in JAMA. One of our fellows, Chetan, published this. And if you look at this, most of the patients with the stroke do not go home. Only 30% go home. They go rehab, and ultimately they have a very poor quality of life. However, some people argue that, are we better than surgery? Yes, we are better than surgery. Surgical stroke risk is more compared to TAVR stroke risk. There is no question about it, and we analyzed it very thoroughly, and we found the same thing, that the surgical stroke rate is higher. But even though surgical stroke rate is higher, this is not our goal. Our goal is like to PCI stroke rate, which is 0.1%. So 2% stroke rate is tremendous. So with Sentinel, there was a decrease in the stroke rate at 72 hours, but this was not our primary endpoint, so that's why we are doing the PROTECT TAVR study. This is Cleveland Clinic data from last year, so this year's data I'll show you at the end. So we had 500 TAVRs. We had 1% that died. Jehovah's Witness had GI bleed, and she didn't want transfusion. Otherwise, we didn't have anybody. 95% had Sentinel successfully placed. Only one stroke, and the stroke unfortunately happened in the patient that we didn't put a Sentinel device. Majority were high-risk patients. Surgical conversions were 0. How do we deploy the valve? So most people deploy the valve in an LAO projection. We stopped that about 3 years ago or 5 years ago. So we deploy the valve in RAO projection. So we always put we very simple, no CT scan, nothing. When we put the valve, we align it just like core valve. We make it, take the parallax out, and the valve shortens exactly, luckily, to that line. Where you see that line, you will see it again. I'll let you see it. You see that line, the radiolucent line? The bottom of the radiolucent line, that one sheet will shorten. So we put it at 0. We put a straight flush catheter, not a pigtail catheter, right in the sinus. So right in the sinus, there is a catheter, and look at that. We are putting it right at the 0, and we have a biplane lab. So if you check it in the LAO projection, it looks horrible. It looks like we are going to embolize the valve, or it is going to be super high. It is not super high. It's perfect. So the risk, so we are deploying the valve at 1 millimeter. Average depth is 1.4 millimeters. What that has done to us, and this paper is in press, so not yet published, but if you look at this, our pacemaker rate was 5.5%. 5.5% in 500 patients last year, including right bundle branch block, whatever bundle branch block you have, no problem. And then we do an echo at the end to say that if it's good or not, and everybody, we do a hemodynamic study. So this is a nice paper to say that you can do the AR index, but now the AR index with rate-related AR index. And you can also look at that whether the dicrotic notch, this is an interesting observation. We also published that, that's the reference below, that the dicrotic notch is above 50%, then you are good. So if the dicrotic notch in the slope is above 50%, that's a great news. That means you are in a good place. If it's not, then it's different. And then everybody, we do an aortogram. Everybody has an aortogram, 20 cc's per second, 20 cc die. And then there's a very interesting thing, this is also in press, that we take the pacemaker out of the ventricle and now put it in the atrium. And then pace the atrium. And with Dr. Colombo and with Azim, we did 2-center study. And then if we can pace it at 120 beats per minute, and if we go 1-to-1, that means that there is no HV block at 120 beats per minute. If you have a Vankeback, then you cannot test the HV. Vankeback happens at AH, so the atrium to his bundle area. So if you have that, then you cannot test it. But if you do not have that, so in 70–80% of our patients, we can pace at 120 beats, the ventricle from the atrium. Then we just discharge them. This is 219 outcomes. This is only half a year, because I don't have the complete year outcomes. So we will probably do 700 TAVRs this year. So we have first 2-quarter TAVR, 330 patients, 60-40 high risk and intermediate risk, 91% with conscious sedation. The only 9% with general anesthesia are the people that had alternative access. No mortality yet, knock on wood. we had 1 stroke, 0.3%. 2+ or more AR was 0.3%. And new pacemaker this year is 1.2%. So TAVR for all, I say, yeah, TAVR is to be for all. Consider TAVR for everybody. If they're not good TAVR candidates, as we mentioned many times, that if coronaries are going to be closed, annulus is bad, bicuspid aortic valve, then you consider SAVR. And if the SAVR is not a good option, then you again come back to TAVR, high-risk TAVR. But otherwise, if you're a low-risk TAVR candidate, there is no real good reason at this day and age to do SAVR, unless you are going to put a mechanical valve where you need a very young patient. Thank you for your attention. And now we will hear about the last lecture.